So good afternoon, and thank you all for joining us on this National Healthcare Decisions Day. I'm Dr. Wilcox, Community Coordinator at the New Jersey Healthcare Quality Institute. The Quality Institute is a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. A public health crisis such as the one we are now facing with COVID-19 tests our strengths and highlights our weaknesses. At the Quality Institute, we are going to continue to have important conversations about today's toughest healthcare issues remotely through webinars, quality briefings, and other valuable resources such as this presentation. We will get through this together by communicating best practices and learning from each other. Before we begin, a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit background noise. You may ask questions at the end of the presentation by typing into the chat box. The topic for today's presentation is being prepared, advanced care planning at home, in your community, and with your provider. By the end of this webinar, you will learn why having end-of-life conversations in your community is important and affects outcomes, tools and resources to make having end-of-life conversations at home more accessible and comfortable, why end-of-life conversations should be part of a provider's plan to deliver excellent care, and best practices for healthcare providers to have advanced care planning conversations with patients and families. Please be advised, it is not the intent of this program or its speakers to provide clinical or legal advice. We are honored to have Teresita Tacey Silverberg Urian, RN, BSN, CHPN, end-of-life specialist and founder of Advanced Choices, president of the Hospice and Palliative Nurses Association, Northern New Jersey Provisional Chapter, and Dr. Vikranta Sharma, MD, Medical Director of Hospice and Palliative Care at the VNA Health Group, as the expert speakers for this webinar. Both Tacey and Dr. Sharma participate in the Quality Institute's statewide community health initiative called Conversation of Your Life, also known as COIL, which is a program of our Mayor's Wellness Campaign and generously supported in part by the Horizon Foundation for New Jersey. COIL aims to improve end-of-life care planning from a cultural and community perspective and engages communities and residents in conversations around advanced care planning. We discuss topics such as end-of-life care options like hospice and palliative care, various advanced directive documents, and how to communicate your end-of-life wishes to your loved ones and healthcare providers. COVID-19 is prompting many people to consider the advanced care directives they may have been putting off and to talk openly about what matters to them most. We have compiled trusted resources, all accessible from home, to help residents and families start thinking about their wishes and how they can comfortably approach these important conversations with loved ones and their healthcare providers, as well as put their wishes in writing. We encourage you to share this document on advanced care planning, preparing for the unexpected, widely with your loved ones, patients, colleagues, and members via your social media channels, websites, and/or newsletters. And please stay tuned. COIL will continue to push out resources such as one-pagers and webinars for residents and healthcare providers. Without any further ado, I'd like to turn over the presentation to Tacey, who will discuss why there is a gap between the number of people who believe talking with their loved ones about end-of-life care is important and the number who actually take action to document them, as well as the best practices to begin the end-of-life conversations. Tacey, the floor is yours.
Thank you, Dafa. Let me just get my PowerPoint up here. Well, good afternoon. My name is Tacey Silverberg Urian, and I'm a certified hospice and palliative care nurse. I'm sorry, hold on one second. I founded Advanced Choices because as a nurse, hold on one second, I'm sorry, I'm having a problem with my technology here. Just give me a second. I'm sorry. It's technology. Okay. After my years of face-to-face and hands-on experience in hospice and palliative care nursing, I recognize that there is a need to educate families on preparing for end of life. I believe that talking about end of life wishes helps create the opportunity for a more peaceful death. As chair of the Essex County COIL Task Force, I'm happy to be talking to you today about the importance of one's advance directive. I'll review various tools to make it easier to talk with loved ones about your end of life plans, and hopefully you'll begin to develop a death literacy, a language to make talking about death more natural. For the past several years, my role as an RN hospice clinical liaison was to conduct family meetings in the hospital and to discuss goals of care and to explain the options of hospice and palliative care. Most of these patients were suffering from end-stage disease, heart, kidney, lung, dementia, or cancer, and others who were elderly and medically fragile. They were all being kept alive with artificial means. These families were very distraught because they could see that their loved ones were suffering, and their physicians were sometimes being vague about their loved one's condition or prognosis. All too often, I found no advance directive or proactive discussions about what to do in this situation. And these families now were being asked to make difficult decisions. Should they make their loved ones a do not resuscitate, disconnect life support? Could they elect comfort care with supportive hospice? Making these decisions during a time of medical crisis is wrought with feelings of anxiety, anger, guilt, sadness, and uncertainty. Emotions are very high, and this is why we need to have these conversations long before we end up hospitalized in a medical crisis. We need to be prepared. If only our current death-denying society could embrace a culture where we begin these conversations in the community. There's a saying that goes, "It's never too early until it's too late," in reference to having these end-of-life conversations. My objective for today are for you to understand that it's not unusual to feel uncomfortable talking about death. We live in a death-denying culture, and we do not have the skills or vocabulary to speak about it. But we all know that as far as the life cycle goes, there's a beginning and there's an end. Death is not optional. So we might as well have something to say about it. Because of this coronavirus pandemic, many of us have become acutely aware of our mortality. So how do we broach these topics with our loved ones? And where can I go to complete my advance directive? Later on in this presentation, I will review some of the tools I use as a COIL volunteer. According to the Conversation Project, 92% of the people say that talking with their loved ones about end-of-life care is important. Yet, only 32% have actually done so. There's so many reasons for this, and according to the Conversation Project, 21% say the reason they haven't had the conversation is because they don't want to upset their loved ones. Other reasons I hear are varied, but according to the Conversation Project, 53% say they'd be relieved if their loved ones started this conversation. What this data tells me is that we as a society want to have these important conversations, but we don't know how to start them, or we don't know how to have them. I'd like to share some of the common questions I hear in the community. They include, how do I prepare these conversations? What types of things do I need to consider? Or this is a common one. Whenever I've tried to talk to my adult children, They don't want to talk about it. What's the best way to approach this delicate topic? What are some good conversation starters? How can I segue into these discussions? There are so many different forms. I'm so confused. Is an advance directive the same as a will or a healthcare proxy? Where can I obtain an advance directive form? Do I need a lawyer in order for my advance directive to be legal? What's the difference between an advance directive and a living will? Well, of course, having these conversations are difficult and tricky. We're uncomfortable talking about death or the process of dying. It can be morbid and scary to talk about it. But on the other side of this coin is even scarier. I've met families that were prepared with advance directives. They were calm and knew exactly what their loved one wanted them to do. And others who were not prepared or had no clue what their loved one wanted. These families were angry, distraught, confused, and anxious. So let's take advantage of this time while we're sheltering in place to begin thinking about your wishes. For those of you who need a little help with this, let's take a look at my favorite tools listed here. The Conversation Project, Death Over Dinner, the 5 Wishes, and a card game called Go Wish. Let me explain why I prefer these tools. On the Conversation Project website, there are multiple resources. It's a great tool to use to help you get your thoughts together and to prepare to have the conversations with loved ones. Community members love this site because it's user-friendly and helpful. I truly like their booklet, Your Conversation Starter Kit. It contains multiple conversation starters like, I need to think about the future. Will you help me? Or, I was thinking about what happened to Aunt Joy, and it made me realize, and so many others. These booklets are free, they're downloadable, colorful, and easy to use. Now, I've conducted 2 Death Over Dinners in my home, which is fun and a very effective way to talk about end of life. My guests arrived feeling tentative and anxious, but always left feeling appreciative because they were able to talk about their end of life wishes, fears, and concerns. As the evening progressed, I noticed that as soon as one of the guests began sharing a death story, then the others would begin sharing theirs. Of course, having dinner also creates a more relaxed atmosphere. What I like about this end of life awareness campaign is that the host utilizes the site's web program that automatically creates invitations that contain simple tools to help your guests address their fears, hopes, and how they want to be remembered. And for healthcare professionals in attendance, there's a healthcare edition created specifically for hospital staff. In fact, I heard that this edition was piloted with great success recently at a New York City hospital. They provide CEUs for physicians and nurses. Now let's move on to the 5 wishes, which is an advance directive or a living will with the heart and soul. I prefer this advance directive because not only does it meet the medical and legal criteria of naming your healthcare proxy and developing your wishes regarding end-of-life medical care, but then it includes 3 more wishes that focus on your personal, emotional, and spiritual needs. It becomes a legal form once you sign it and you have 2 witnesses not related to you witness your signature, then sign. And lastly, the Go Wish card game. This is designed to help you find words to talk about what's important if you were living with a serious illness. It's designed to be a way to talk about your priorities. You can order the physical deck of cards, or you can play using their new online version. Well, here are the websites, and I also included them on the resource page at the end of this slide presentation, which will be made available after this webinar. Now let's talk about National Healthcare Decisions Day. Last year, and prior to this COVID-19 pandemic, we COIL volunteers provided end-of-life workshops that included topics on elder care, completing one's advance directive, funeral planning, and other topics in our communities. And we provided them at senior centers, town halls, parks, libraries, hospitals, universities, and religious institutions. This year, we were forced to be more creative and developed an online webinar and offering it up to the community. So I collaborated with another COIL volunteer, Karen Martineau, who's the founder of Bevival, which is a death literacy content platform, and we developed the 5 Wishes Made Easy. Over the next 2 weeks, we're going to be offering this free online webinar to talk about the 5 wishes and walk the attendees through the booklet. We recognize that completing one's advance directive may take several conversations as you consider your values and beliefs and talk to others. So if you're interested in attending one of these sessions, you can register using this link. A few days prior to the session, you'll receive an email with a link to Zoom webinar and details to download a free 5 Wishes booklet thanks to the generosity of Aging with Dignity. During this session, we will walk you through it step by step, followed by a Q&A session. Lastly, I've compiled additional resources that you might find useful. The New York Healthcare Quality Institute Conversation of Your Life created that amazing informational guide in regards to advanced care planning in response to COVID-19 pandemic. Here, you'll also find additional end-of-life advanced planning resources. For healthcare workers, I recommend the New Jersey Coalition on Goals of Care website, where you will find great information on posts, care planning tools for clinicians, and their 4-step I-Care plan that help with difficult medical decisions and how to communicate them. The New Jersey Department of Health Advance Directive website contains the New Jersey Medical Advance Directive, posts, and other helpful information. They also have resources on where and how you can store your advance directive in the cloud. Well, I hope you enjoyed learning about COIL in the community and the importance of completing one's advance directive now versus waiting for a medical crisis. Please check out my favorite tools. I feel confident that you'll feel more comfortable with these important end-of-life conversations if you utilize them. But right now, what I wish for you is to be prepared, especially during this time of COVID-19. Step 1, complete your advance directive. Step 2, pick a person to be your healthcare decision maker or proxy, and then talk to them about what matters most to you in the end. And step 3, make an appointment with your primary care provider to discuss your advance directive. You can even set up a telehealth visit. If you have any questions, please submit them to the chat box, and I will try my best to answer them after this session. That's it for now. Thank you for attending, and now I'd like to turn it over to Dr. Sharma.
Thank you, Tacey. That was a wonderful toolbox that you shared. I want to thank New Jersey Healthcare Quality Institute for giving me this opportunity on National Healthcare Decisions Day to address the importance of advanced care planning in the current setting. With that, I'm going to share my screen with Tyler. Are we on?
Not seeing your slides yet. Just hit
There
the
you go.
share screen button at the bottom.
Share.
There you go. Oh, we need your, just make sure your document's open first.
There you go.
There you go. Perfect.
All right. So the objectives for today's conversation from my side is to understand why end-of-life conversations should be a part of a healthcare provider's plan to deliver excellent healthcare, and what are the best practices that a provider can use with patients and families. I have no financial disclosures. I am the State of New Jersey Task Force member for the COIL, as well as for the Provider's Order for Life-Sustaining Treatment Committee. I have been part of the COIL since its inception in the Princeton community. I'm part of the Monmouth County COIL Task Force also. I'm the Medical Director for Hospice and Palliative Care of DNA Health Group, and I've been practicing as a palliative care physician since 2006 in New Jersey. I am also a part of the teaching faculty for the Family Practice Department in Rutgers Robert Wood Johnson Medical School, Family Medicine and Community Health. I want to say that advanced care planning is important at any time, knowing the healthcare system, where it stands in the United States, and the evidence of significant chronic comorbidities present in our population. But now more so than ever before, it is crucial for us to have these conversations well ahead of time and not have last-minute conversations, because we know planning is the best way we can tailor our healthcare that is aligned to our wishes and the wishes of the families, and not receive unnecessary or burdensome care. So from the guidelines that have been shared by various countries in the current pandemic of COVID-19, I will share with you the 3 different severities of the COVID-19. It is classified into mild, moderate, and severe disease. Mild disease is characterized by fever, cough, and shortness of breath. These are the most common symptoms that an individual might have. In moderate disease, people usually have severe shortness of breath. They are hypoxic, and they have multi-lobar interstitial pneumonia. Usually these individuals require hospitalizations. In the hospitalized patients, the disease can usually progress to a more complicated disease by needing ventilation. If their oxygen drops so much that they need ventilation, they might become septic with an inflammatory response. We're finding thrombosis in the lungs, in the kidneys, in the gut, and in the brain. People are developing adult respiratory distress syndrome and acute kidney injury requiring dialysis. There's really no clear-cut treatment available, nor is there a vaccine in place at this time, although NIH and CDC both are working diligently towards both of these. Therefore, the main treatment is supportive care. And that kind of leads on to the next point, that in these situations, throwing the kitchen sink at an individual that is chronically ill may not be in their best interest and may not result in the best outcomes. So focusing on what is important to the patient and family is more important now than ever before. Quickly going over the general guidelines for COVID-19 pandemic, we are observing social distancing, washing our hands for 20 to 30 seconds with soap and water, or an alcohol-based sanitizer when it's not possible to wash with soap and water. Frequently cleaning surfaces with disinfectants at least twice a day, and having restful about 8 hours of sleep is very important. Having exercise and meditation as a regular part of your repertoire of the day is equally important, along with a nutritious diet. To treat patients at home, we're using antipyretics like Tylenol, antihistamines, fluid, rest, prone positioning, that is lying down on the stomach, and judicious use of antibiotics and antivirals when we think there's an underlying bacterial infection or an influenza pneumonia. Flu shots and pneumonia shots are still relevant, as they might prevent severe disease in people with chronic illnesses. In the hospitalized patients, usually the reason for hospitalization is a multilobar pneumonia, an exacerbation of other diseases like chronic obstructive pulmonary disease or congestive heart failure. These individuals usually are needing oxygen at a much higher level than that can be afforded at home. The first decision point comes in the hospital: that do we anticipate them to land in the ICU or not? And if they're going to land in the ICU, if their disease is progressing so quickly, it is really important to address the anticipated course in ICU with the patient and the family, requiring ventilation, going through high pressure ventilation, developing possible barotrauma like subcutaneous emphysema, septic shock, thrombotic states with clots in the legs, lungs, brain, or kidneys, developing acute kidney injury, and the possible need for dialysis and ECMO needs to be underscored. All the same precautions are available in a facility in the hospital, with the advantage of negative pressure rooms to prevent further spread of the disease, and other supportive trials like remdesivir and other experimental drugs ongoing. So it's really important to lie on your stomach if you're feeling short of breath and you have COVID pneumonia. The way we are treating nursing home patients is exactly the same as if they were being treated at home. We isolate them if they have been exposed to COVID. We keep them in quarantine or isolation until, if they have the disease, we isolate them for 14 days or until they have no symptoms like fevers or shortness of breath or cough for at least 48 hours, or they are COVID negative. We're using Tylenol, antihistamines, fluids, prone positioning, and we're addressing and establishing their healthcare proxies and advanced directives in a haste if they are not already established. We want to focus on the fact if they have a terminal condition like advanced dementia, heart failure requiring oxygen, lung disease requiring oxygen at a basal state. And we're trying to address if they have a condition that might cause them to be admitted to the hospital and requiring an ICU stay. And is that ICU stay really advised, or it is ill-advised and will add to the burden of the disease and make the quality of life worse? We need to discuss do not hospitalize if the goals of care imply that comfort-focused care is desirable to the patient and accepted by the family. Some of these individuals are better served by having familiar staff taking care of them in familiar surroundings, as the strict isolation atmosphere offered by the hospital may unmask delirium in these individuals, making it harder to take care of them in the hospitals. We are recommending double masking these individuals, residents of nursing home, as well as the healthcare workers, to prevent further spread. So why is identifying end-of-life goals important? We need to recognize that as death nears, most people share similar goals. They want to maximize time with family and friends in familiar places. We want to avoid unnecessary pain and suffering, and we want the doctors to make appropriate treatment plans to avoid these symptoms. Patients want to maintain their functionality and dignity with supportive care, aides, and loving caregivers as far as possible. They do not want to be a burden on anyone, if possible. And they want to try and identify, providers need to clearly identify and attain milestones for the patients that they wish to reach. For example, if somebody wants to attend somebody's birthday or graduation ceremony, even in today's date, that can be arranged by FaceTime or audiovisual tools such as Zoom or FaceTime. As Stacey already mentioned, formal contact with hospice and palliative professionals is available and should be offered when discussing end-of-life goals with patients and their families. It's really important to understand the importance of autonomy, and Patient Self-Determination Act underscores that capacitated adults have the right to make their own healthcare treatment decisions. So why should end-of-life care conversations be a part of the provider's plan? That's because care aligned with patient preferences and goals is the best care. This may differ sometimes from standard of care. However, physicians are uniquely positioned to help them make these shared decisions by discussing their insights about treatment plans, disease course, prognosis of the disease with treatment and without treatment. We should focus on establishing a respectful relation with the patient by understanding their values. What do they hope for? What do they fear the most? What are their current support systems? What logistical support do they have in their home or in their community? The idea is to help them plan for a future they might face if they're not able to speak for themselves. So advanced care directives only go into effect if the patient is not capacitated. Right now, about 30 to 40% of the adults have some sort of advanced care directives. The numbers are growing rapidly every day. Ensuring that an individual's wishes are known and honored requires serious reflection and candid discussions with family members and healthcare providers. There are 4 steps for advanced care planning: reflection, communication, documentation, and implementation of those plans. Reflection on the priorities. Do I wish to spend the rest of my days or weeks towards the end of life in a nursing home? What sort of disability is absolutely unacceptable for me? Who will care for me when I'm physically incapable? Hospice and palliative care allows patients and families to establish a relationship with the care team over a period of 6 months of time to allow for a respectful relation and codependence in these difficult times. What place do I want to be at the end of life? Certainly a familiar place is more helpful than an unfamiliar place and appointed by strangers who, even though they mean to do the best things for you, you may not be comfortable with them. Let's talk a little bit about the healthcare proxy. A healthcare proxy has to be someone whose values match your own. It's not necessarily your eldest child or your spouse, especially if you don't see eye to eye with your philosophy of life and death. They should agree with your decisions of needing support or not going through aggressive care. It can be a friend. It doesn't have to be your family. It can also be a legally appointed guardian. So what are the indications for doing advanced care planning? Healthcare providers need to identify declining functions by addressing what activities of daily living they can do. For example, can they dress on their own? Can they bathe on their own? Can they toilet on their own? Are they feeding themselves? Are they transferring from bed to chair by themselves, or do they need help? And do they need adaptive adaptations to ambulate or walk? Identifying major chronic illnesses, like Stacey said, CHF, COPD, end-stage liver disease, advanced kidney disease, advanced neurodegenerative conditions like dementia, Parkinson's, ALS, or multiple sclerosis. Very frequently, these individuals have had frequent hospitalizations, ER visits, observation unit visits, or more frequent visits to their physicians. This is the prognostic side sign and needs to be taken as an opportunity to proceed with advanced care planning for their future. Recent serious hospital admissions should also offer an opportunity to have advanced care planning conversations. Also, presence of acute strokes or person permanently living in long-term healthcare facilities with dementia, frailty, or other neurodegenerative conditions are prime candidates for having advanced care conversations and planning for their future. Some patients have unique preferences for no blood transfusions or not going to the hospital, and those should take precedence and guide us in our conversations. So one of the protocols that I like and has been academically reviewed across the healthcare systems is the SPIKES protocol. SPIKES stands for setting up the interview, assessing the patient's perceptions. I stands for inviting the patient to give you the permission to have that conversation. And then K for knowledge and information to be imparted to the patient by the provider. And then addressing the patient's emotions with empathetic responses and summarizing your meeting with the patients and family and setting up a follow-up. So the setting needs to be respectful in a quiet place where phones are not active, buzzers are not buzzing. It's really important to sit down and be in the moment and gather all the data and review the consults prior to a visit with a patient. Allow the family to talk and let them tell you what they have been told by other physicians so you can sort out the confusion or difficult questions that they might have. Remember that most decisions are still made collectively by the family, even though one person may have been appointed as a healthcare proxy or power of attorney. Listen to what they already know. Ask for clarifications. How has the patient deteriorated functionally, nutritionally, and mentally in the last 6 months? That's a really important prognostic indicator. And very frequently, my patients will paint the picture of the decline that they have seen in the last 6 months. Sometimes it is difficult for the providers to know how much to tell the patients. I have a policy to usually ask the patient, are you the kind of person who wants to know everything, or would you rather I talk to your son or your wife? Some defer it to the family. Remember that sharing information may be a valid coping mechanism for some individuals. So focusing on shared decision-making implies that you have, you're doing it in an empathetic setting and you deliver the knowledge in a simple language, not in medical jargon. Avoid blunt statements and impossible choices, like going through a surgery or dying instead. No one is going to choose to die, but understanding what the risks and benefits of the surgery or the procedure or the hospitalization might be, might clarify their decision-making ability. Give small chunks of information and check for understanding frequently. Avoid statements that take away hope, like nothing more can be done. Offer that comfort care can be done always, and they will not be left alone. They will not be in pain, and they will not be suffering. Addressing emotions like silence, disbelief, crying, denial, or anger is hard to do, especially when you're delivering difficult news in an intimate setting, in a very in an atmosphere that is fraught with emotion. But it's really important to remain silent, give the other person time to express, and try and understand the reason for the emotion they're having. Sometimes just being silent for a few minutes is helpful in the person dealing with that emotion and then moving on to the next part of the conversation. So here are some examples for empathetic responses. I think it's really important to underscore how important and how difficult it is for the healthcare providers to have these conversations, equally as it is difficult for the patients to understand and deal with this also. I find that people focus a lot on their family, on their children, and it's really helpful to explore that option more. You mentioned that you're concerned about your children or your family. Tell me more about it. Tell me what worries you most. In the end, it is really important to validate what they have understood. Your understanding of the disease and its effect on you is very good. It appears that you've thought this through with your family. And many people in your circumstances have chosen the same decision making. So in the end, the takeaway summary is that our goal is to have an understanding of the patient values and begin to plan for patients' future medical care in a non-threatening way. It's important to do a signposting before you start this conversation by saying that I wish to put something else on the agenda apart from discussing pain or treatment, and normalize the process. Tell them it's okay not to have had an advanced care planning document in place, but it's important to have it now, and take a moment to explain why it is worth thinking about. Talk to them about surrogate decision maker by giving them a choice A or B. It could be your wife or it could be your friend, rather than just saying the next of kin. Hope for the best, but plan for something we are hoping doesn't happen. Tell me what does being peaceful look like to you? And tell me what not suffering means to you. So with that, I'm going to end my presentation. I hope this will be helpful for nurses, nurse practitioners, and physicians to deal with the difficult pause points or decision-making times and focus on what the individual wants and what their family preferences are. With that, I will pass the screen back on to Tyler. Thank you.
Oh, no, first, before Tyler comes back, I just wanted to say thank you for the helpful information to both Tacey and Dr. Sharma. I'm going to ask a few questions that I have first, and if those of you participating have any questions for Tacey or Dr. Sharma, please continue to type them in the chat box or the Q&A section, and we will get to as many of them as we can in the time allotted. First, for Tacey, I wanted to know, how can COIL task forces create virtual programming to keep their communities engaged while we are participating social distancing?
Well, like I had shared earlier, another COIL volunteer in the Essex County Task Force and I collaborated to decide what type of programming would be of interest for the community. And we already knew that a hot topic is always around completing the 5 wishes. So it was a no-brainer that we decided, well, let's create a webinar, make it available via Zoom, and just broadcast it out there. So how we went about that is we just went ahead and developed the script. We went back and forth, a lot of iterations to make sure that it was engaging and interesting and that it made sense. And then it's also very important to keep engaged with the community leaders to make sure that, you know, they understand that these webinars, or we're even thinking about podcasts, are going to be available to the community members. We wrote a letter to the editor so that neighbors, our community, will know that this is happening, and also that it's National Healthcare Decisions Day month. And we use social media, Facebook, Twitter, to announce the event. So these are all the things that we're all learning to be more competent in as we are forced to do more social distancing and sheltering in place.
Thank you. And for Dr. Sharma, why should providers take a moment to fill out their own advance directives during the COVID-19 pandemic?
That's an excellent.
Oh, seem to have lost you. Oh, go ahead.
That's an excellent question. My personal experience has been that a lot of us healthcare providers are getting a concentrated dose of aerosolized infection in the hospitals and by being in personal contact with these individuals. The likelihood of healthcare workers falling sick is much higher because of the dose of virus that they might be exposed to over the course of days, seeing about 10, 20 patients in a day. Currently in Italy, they've announced 100 doctors have died of COVID-19. In US, yesterday, there was a paper that came out in New England Journal of Medicine that 23 physicians have died so far. So the difficult work that we do, unfortunately, does put us in the harm's way. And it is really important for us to address those healthcare planning documents ahead of time. My own sister works out of Brookdale Hospital. She unfortunately contracted COVID-19 and was quite severely sick with oxygen saturation of 86% at home, and decided that she was not going to go into the hospital to be ventilated if the time came. So she had that documented and made it very clear to us. Fortunately for her, she was able to recover well enough to be back on front lines. But I think that underscored to me the importance of documenting it. In historic terms, in the smallpox epidemic, people used to have smallpox parties. And historically, it was found that the dose of virus that they got if they actually conducted a smallpox party at home was that they got a higher dose and the patients became sick a lot more, as opposed to if they got it in the community by playing with children, for example. So historically, it makes sense for healthcare providers to do their health care planning documents and appoint a healthcare proxy and let other people know what their wishes are.
Okay, well, thank you for sharing that. And I have one last question for the both of you. What would you say is the most important thing for people to address in their conversation about their end-of-life wishes with their family and or providers?
It's okay for me to take it?
Mm-hmm.
I think it's most important things for people to address is what's important to them at the end, like being kept comfortable, like Dr. Sharma said, and also to ask them to define what it is that is worth living for. Like I can share with my elderly patients, when they were nearing the end of life, they were very clear with us that if they became a burden, or if they weren't able to feed themselves or be able to communicate with us, they said, there really is no reason for them to continue living. So the four of us kids knew that when these things happened, that we were not going to medicalize their death. We were not going to rush them off to the hospital. I think writing it down and having an advance directive is really wonderful to do, but I think it's most important just letting your loved ones know what is important to you in the end so they can advocate for you.
I second that very much, Stacey. My favorite thing has been to ask a simple question. I think all of us need to answer a simple question like, what does peaceful death mean to you? And visualizing that, the place, the people, the surroundings, and the atmosphere. So no one wants to be in pain and suffering. So having appropriate medications available to you, being in familiar surroundings, and surrounded by people who love you, and being able to say thank you, goodbye, and leaving a legacy. Those are all the things that have come out from end-of-life care related research that has been conducted by American Academy of Sciences and Institute of Health. I focus on what does a good, peaceful end-of-life care look like. That's a very, what does peaceful look like to you, or what does not suffering mean? Those are important questions for me.
Got it. Okay, thank you. Those are all the questions that I had at the moment. So I'm going to turn this over to Tyler so she can get to the chat and Q&A questions that you guys posed.
Thanks, Deb.
Thank you. And for folks that have questions, we have about 10 minutes left. So if you have questions, type them into the chat box or the Q&A box, and we'll get to as many as we can. I have a couple good ones so far. One that just came through, I think this is a great question. Can seniors access hospice care if they are COVID-19 positive and don't want to go to the hospital? And if so, can they or their family establish contact with a hospice care provider to prepare paperwork in advance?
Well, okay.
So the hospice eligibility is a very narrow, hospice is a very highly regulated industry. CMS has very specific guidelines for terminal diagnosis of a patient being established. So, and if you have advanced heart disease that you are on, you have been on multiple medications but are still symptomatic. If you're using oxygen, again, same for advanced lung disease. If you've been on medications and you're not improving and you're on oxygen already all the time, those are criteria for eligibility towards hospice. If you have advanced liver disease because of hepatitis or cirrhosis and are requiring withdrawal of fluid from your abdomen repeatedly, or if you have advanced kidney disease and have been on dialysis and you're thinking that if you have COVID, you don't want to go into the hospital or might stop dialysis. If you have advanced cancer and the treatment has not made it better and it is progressing, you might be able to apply, might be eligible for hospice. A hospice medical director has to review your medical report or history and agree that you have a terminal prognosis of 6 months or less. Some individuals with dementia might be eligible if they contract a concurrent illness like urinary tract infection, pneumonia, or, for example, COVID pneumonia. So they might be eligible. But there are guidelines. So now more than any other time, it is really important that we don't put people on hospice just because of COVID. COVID in itself is not a criteria because there are individuals who are improving and not dying acutely. However, if they are seriously ill in the process of dying, yes, it can be done, although it is going to be harder in today's shelter in place to find appropriate staffing, etc. Many hospices are struggling with staffing and organizing COVID teams to do this. So the short answer is yes, a person with chronic illness who contracts COVID-19 can opt to obtain hospice at home by contacting a hospice agency. There are many agencies in New Jersey, and any of one can be contacted. You can go to New Jersey Home Care and Hospice Association to look at the number of hospices that are available. VNA is one of them. And so that's the answer to that question from my standpoint from eligibility.
So I'd like to add a little bit to that because I have been in contact with my colleagues from the hospice organizations, and I agree 100% with what Dr. Sharma had to say. But they are admitting patients with COVID-19 that are experiencing respiratory failure in the home. They've been treating them, symptomatically with, opioids and other palliative types of medications, of course, with the goal of comfort and making sure they're comfortable. Mm-hmm. I would recommend, because in our state and many states, if 911 is called, the EMS does have to start resuscitation. So one of the important documents I would recommend for any elderly patient that is thinking they don't want to be hospitalized, and to make sure that they have paperwork in place if they're at a facility for do not hospitalize or do not intubate or do not resuscitate. Make sure these things are in place in the home or assisted living facility or any of the facilities before they, because as we know, the course of this disease could be very rapid. So you may not be able to get all that paperwork in place, as soon as they're diagnosed or became symptomatic. So my recommendation would be to have these conversations with your primary care physician before, if you're thinking you don't want to be brought to the hospital.
Great, thank you, that's very helpful. And a couple of questions, I'm going to combine them all. I think for a lot of folks, they feel like advanced care planning might not be the right topic right now because people are so sensitive, but yet we all know that it is more important now than ever before. And Dr. Sharma, I think you touched on this a little bit, the approaching patients and talking to them in a way that's sensitive to their feelings and their needs. Anything that either of you could talk about right now as it relates to COVID-19 that would help sort of have that conversation and make folks understand how important it is, even more so now than ever before, especially with Dr. Sharma, you mentioned the severity of the symptoms that folks are experiencing now.
Right. So what's really hard for physicians and patients alike is the uncertainty of the course of the treatment. It is a novel coronavirus, and we don't know who is going to have mild disease, who's going to have moderate disease, and who's going to be severe enough to reach the stage of ventilation and septic shock or ARDS. Therefore, it is really important to know what the disease potentially can do, and be open that if it progresses to a point where I'm going to likely end up being on a ventilator, is it important or not? I think it's hard for the providers because it's an infectious disease, and traditionally we are able to treat most infectious diseases, even if they are very severe. So we hope that there will be light at the end of the tunnel, and we have treatment as well as a vaccine available in the next year or so. I think for the patients, I'm experiencing that it's hard for the family members. Sometimes with patients with chronic diseases who contract COVID are not declining as expected or as quickly as expected. They're hospitalized and they're thinking, oh my God, they have heart disease, they have kidney disease, they have frailty. They've been living in the nursing home now for about 6 months, and they're not deteriorating quick enough. And I remember that I had one patient family that I had to tell that, we still can't time that. That's still not in our hands, that we need to, if we are able to focus on patients' symptoms and keep them comfortable and their body allows themselves to heal, even if for a short period of time, that is a victory. So just staying on the edge of the tide where you're not taking away hope and yet allowing their body to come back as possible is a difficult balance at this time. Did I answer your question? I didn't.
Yeah, absolutely. I think it's important to understand like you said, the severity of the illness, and that there's a lot that's unknown. So having those conversations is even more important now.
Honest conversations now are much more effective than saying this is going to happen or that. Postulating is not as important as acknowledging uncertainty and being humble about it and say, if we get him home, well and fine. If we get them to a nursing home, well and fine. If they pass, should it come to a point that they are suffering, we don't want to prolong their suffering. We want to make sure they're comfortable because the disease is going to take its course anyway. And that's usual conversation for any chronic disease in any case. But now more than anything else, I think that's becoming more prevalent and important.
Absolutely. And I know we're just about at time, we're just over actually. So I just wanted to share with folks not only a prompt for our next webinar, which is next Wednesday. We're going to continue on talking about telehealth, which is obviously very important right now for everybody, but maintaining primary care during telehealth, or using telehealth to maintain primary care during the COVID-19 crisis. We are talking a lot about and wanting to make sure that folks are still accessing preventative primary care, and as well as managing their chronic diseases during this time while being safe and not getting exposed. So we're going to have Dr. Ambrosio and Jennifer on to talk about how they as a primary care practice are working with their patients using telehealth and other methods to keep their patients safe and accessing care at this time. And lastly, just wanted to mention that we have all of our COVID-19 resources on our website. We'll be posting the recording as well as slides on our website later today. So you can check that resource link at the top of the screen there for all of that information. We've got all of the webinars in the series that we've done so far, as well as a couple of different resources about advanced care planning, about telehealth, etc. So with that, thank you to DAPA, thank you to Dr. Sharma and to Tacey for your presentations today. I already got a lot of wonderful comments in the chat box. Folks really enjoyed it. So thank you to everybody who attended and for your questions, and we'll hope to see you on the next webinar in the series. Thanks, everybody.
Thank you.
Wonderful initiative. And I just wanted to say that there is CMS has given a special waiver that telehealth services is possible during the emergency time, and advanced care planning can be billed by telehealth during the time of emergency.
Great.
So you don't have to be present in person to do it.
Absolutely.
You can do it over the phone, or you can do it over the FaceTime or Zoom.
Great, thank you so much. And we'll email out a lot of these resources to everybody that attended as well. Thanks,
Great.
everybody.
Thank you.
Thank you all. Take care.
All right, bye.
Bye-bye.